Hello and welcome to Medaculus. Today's topic is lower back pain without radiculopathy. Low back pain often refers to pain in the lumbosacral area from the 12th ribs to the iliac crest, and sometimes the buttocks and gluteal folds. Nonspecific, low back pain has traditionally described pain not attributable to an underlying cause. It may also be referred to as mechanical, musculoskeletal, or simple low back pain in the literature. Some commentators state the term nonspecific back pain is ambiguous and recommend the term nosoplastic pain to describe back pain due to central sensitization, which may coexist with other types of low back pain such as neuropathic or radicular pain. The National Institute for Health and Care Excellence, NICE, defines acute low back pain as lasting less than 3 months, chronic low back pain as lasting 3 months or more. Low back pain may result from a dynamic interaction between social, psychological, and biological factors. Risk factors for the development of nonspecific low back pain include obesity, physical inactivity, occupational factors such as heavy lifting, bending, or twisting, stressful life events, or depression. Risk factors for the development of chronic pain and disability include pain lasting longer than 12 weeks, high baseline pain intensity and disability, anxiety and/or depression, stressful life events including previous or current physical or emotional trauma, previous or current substance misuse, perceived risk of persistent pain, maladaptive coping strategies and fear avoidance, avoidance of work, movement, or other activities due to fear of exacerbating pain or damaging the back, or negative beliefs about pain and activity. Pain coping characterized by excessively negative thoughts about pain and the future, catastrophizing. Past history of other chronic pain syndromes. Possible complications of nonspecific low back pain include impact on daily activities and function including household chores, study, leisure, and sleep, depression and anxiety, time off work, reduced productivity, and loss of employment. The UK Health and Safety Executive, HSE, publication of annual statistics states that in 2020 to 21, 39% of all reported work-related musculoskeletal disorders were due to back pain. Increased risk of falls, immobility, and physical deconditioning, particularly in older people. Chronic pain and possible development of associated chronic pain syndromes. Prognosis. Nonspecific low back pain is a self-limiting condition for the majority of people affected and usually resolves within a few weeks. People who have had low back pain often have episodes of recurrence and may develop repeated, acute on chronic symptoms. An Australian cohort study of people presenting to primary care with acute nonspecific low back pain of less than 2 weeks duration, N equals 973 consecutive patients, found about 50% of people who had reduced their work activities had returned to normal work within 14 days, and 83% had returned to normal work by 3 months. 40%, 52%, and 57% of study participants reported being pain-free at 6 weeks, 3 months, and 12 months follow-up respectively. Pain symptoms took a median of 58 days to recover, and functional impairment took a median of 31 days to recover. Only 72% of study participants had made a full recovery by 12 months follow-up. Symptoms. If a person presents with low back pain, exclude an underlying cause and assess for prognostic indicators to help guide management. Ask about the onset, type, site, and pattern of pain, any pain radiation, duration of symptoms, aggravating and relieving factors, previous episodes, associated symptoms such as morning stiffness, leg pain or weakness, muscle spasm, numbness or paresthesia, weight loss. Nonspecific lower back pain typically varies with posture and time and is exacerbated by movement. Any red flag symptoms that may indicate a serious underlying cause, such as cauda equina syndrome, spinal malignancy, vertebral fracture, or spinal infection. Impact on daily functioning including work, study, relationships, and sleep, and impact on psychological well-being. Pain severity does not necessarily correlate with functional impairment. Any risk factors for nonspecific back pain and a prolonged or complex recovery. Any drug treatments, including over-the-counter medication. Signs. Examine the person. Assess the person's gait, posture, and spine for deformity. Palpate for localized spinal tenderness and decreased range of movement. Assess for any red flag signs that may indicate a serious underlying cause. Consider checking anal sphincter tone and perianal sensation, depending on clinical judgment. Perform a neurological examination and assess for lower limb signs of nerve root compression or other neurological deficits, such as numbness, paresthesia, motor deficits and muscle weakness, or abnormal tendon reflexes. Positive straight leg raising test, extensor plantar response. If no specific underlying cause is suspected, use a risk stratification screening tool, such as the Keel Start Back tool, to identify people with risk factors for prolonged or complex recovery to help guide appropriate management. Do not routinely arrange a spinal X-ray or other imaging to diagnose nonspecific low back pain in primary care. Spinal X-ray may be indicated if there is suspicion of a specific pathology, such as a compression fracture due to osteoporosis or bone pain due to malignancy. Red flags. Potentially serious conditions causing back pain are uncommon but may present with the following red flags. Cauda equina syndrome. Sudden onset bilateral radicular leg pain or unilateral radicular pain progressing to bilateral pain. Severe or progressive neurological deficit such as major motor weakness of knee extension, ankle eversion, or foot dorsiflexion. Recent onset difficulty initiating micturition or impaired sensation of urinary flow. Urinary retention and/or overflow urinary incontinence, late signs. Recent onset loss of sensation of rectal fullness. Fecal incontinence, late sign. Recent onset erectile dysfunction or sexual dysfunction. Perianal or perineal sensory loss, saddle anesthesia or paresthesia, unexpected laxity of the anal sphincter, gait disturbance or difficulty walking, spinal fracture, sudden onset of severe central spinal pain which is relieved by lying down, a history of major trauma, such as a road traffic collision or fall from a height, minor trauma, or even just strenuous lifting in people with osteoporosis, structural deformity of the spine, such as a step from one vertebra to an adjacent vertebra, point tenderness over a vertebral body, cancer, age 50 years or over, gradual onset of symptoms or progressive pain, severe unremitting lumbar pain, thoracic back pain, night spinal pain preventing sleep, spinal pain aggravated by straining, for example coughing, sneezing, or defecation, localized spinal tenderness, mechanical pain aggravated by standing, sitting, or moving. No symptomatic improvement after 4 to 6 weeks of conservative treatment. Unexplained weight loss. Claudication, muscle pain, or cramping in legs when walking or exercising. Past history of cancer, breast, lung, prostate, renal, and gastric cancer are more likely to metastasize to the spine. Infection, such as discitis, vertebral osteomyelitis, spinal or epidural abscess. Fever, systemically unwell, recent infection, diabetes mellitus, history of intravenous drug use, HIV infection, use of immunosuppressant drugs, or other cause of immunocompromise. Differentials. Alternative conditions that may present with low back pain include neurological, sciatica, myelopathy or a higher cord lesion, peroneal palsy or other neuropathies, such as nerve entrapment at the fibular head, deep gluteal syndrome/piriformis syndrome, where the sciatic nerve is compressed or irritated where it is covered by the piriformis muscle, spinal stenosis, systemic, sacroiliitis and ankylosing spondylitis and other spondyloarthropathies, vascular claudication, other, abdominal aortic aneurysm, aseptic necrosis of the femoral head, facet joint arthropathy, greater trochanteric pain syndrome, intra-abdominal pathology, osteoarthritis of the spine or hip, polymyalgia rheumatica, rheumatoid arthritis, shingles, herpes zoster. Managing a person with low back pain. If a person presents with low back pain following a risk stratification assessment in primary care, arrange emergency hospital admission or specialist referral, the urgency depending on clinical judgment. If there are red flag symptoms or signs suggesting a potentially serious underlying cause. Another underlying cause for symptoms is suspected. Offer advice on sources of information and support, such as the National Charity Back Care website www.backcare.org.uk, which has various information leaflets. Offer reassurance and advice on self-management strategies. Reassure that acute nonspecific low back pain is unlikely to have a serious structural cause, and most people recover within weeks. Encourage the person to keep active, resume normal activities, and return to work/study as soon as possible. Discourage prolonged bed rest. Reassure that normal back movements may produce some pain, but this is not harmful if activities are resumed gradually. Advise there is no need to be pain-free before resuming normal activities. Consider the short-term application of local heat, such as a heat pack. Advise to keep as active as possible and exercise regularly to reduce the risk of recurrent episodes. Advise on drug treatment options for symptom relief, if needed. Do not recommend the use of paracetamol alone for the management of low back pain. Advise to use an over-the-counter nonsteroidal anti-inflammatory drug, NSAID, such as ibuprofen first line, if there are no contraindications, at the lowest effective dose for the shortest possible time. Consider the use of gastroprotective treatment if clinically indicated. If an NSAID is contraindicated, not tolerated, or ineffective, consider the short-term use of codeine with or without paracetamol. Take into account the risk of opioid dependence, contraindications, and adverse effects. Do not recommend the use of benzodiazepines for the management of muscle spasm associated with acute low back pain. Do not recommend opioids for the management of chronic low back pain. Do not recommend gabapentinoids, anti-epileptic drugs, or antidepressants for the management of low back pain. Offer advice on exercise programs, manual therapy, and/or psychological support. If a person has risk factors for a prolonged or complicated recovery following risk stratification, offer referral to a group exercise program, biomechanical, aerobic, mind-body, or a combination of approaches. Take the person's specific needs, preferences, and capabilities into account when choosing the type of exercise. Consider offering referral or self-referral to physiotherapy for manual therapy, spinal manipulation, mobilization, or massage, as part of a treatment package including exercise. Consider offering referral or self-referral for cognitive behavioral therapy, CBT, as part of a treatment package including exercise, with or without manual therapy, if the person has significant psychosocial barriers to recovery or other treatments are ineffective. Advise requesting an occupational health assessment, if appropriate, to consider work adjustments to facilitate a return to work. Advise the person to arrange review if symptoms persist or are worsening after 3 to 4 weeks, depending on clinical judgment. Advise the person to seek urgent medical review if there are red flag symptoms or signs suggesting a potentially serious underlying cause. Follow-up. If a person has persistent symptoms after 3 to 4 weeks, or worsening symptoms following initial management, arrange emergency hospital admission or specialist referral, the urgency depending on clinical judgment, if there are red flag symptoms or signs suggesting a potentially serious underlying cause. Another underlying cause for symptoms is suspected. Reassess the person for an underlying cause for symptoms, particularly if there are new symptoms or symptoms change, and manage appropriately. Assess adherence and response to self-management strategies and any drug treatments. Assess for any risk factors for a prolonged or complicated recovery and manage where possible. If a person has chronic low back pain, consider a combined physical and psychological treatment approach. Consider referral or self-referral to a group exercise program, physiotherapy for manual therapy, and cognitive behavioral therapy, CBT, if not already undertaken. particularly if there are risk factors for a prolonged or complicated recovery, or if previous treatments are ineffective. If a person has chronic low back pain and non-invasive treatments are ineffective, consider referral to a specialist back pain service for further management, including possible radiofrequency denervation, which may be indicated for some people.